Um, our next speaker is Dr. Bryan Wells. Dr. Bryan Wells is the Director of Vascular Medicine and the Professor of Medicine at Emory University School of Medicine. Um, he gives an incredible talk on, basic anatomy and what fibromuscular dysplasia is, sort of the basics aspects of it. So I'm very glad that he's talking on here and is with us today. Thank you.
Thanks so much. Welcome, everybody. Thanks for having me. Congrats to Aditya and Esther on putting this together and including me. Always enjoy being here, and this is a lot of fun. And thank you all for being here too on a Saturday morning. And I'm here standing here with gratitude as well. I wouldn't be standing here today if it weren't for some of the people in the front row. I remember when I met Esther Kim at, I believe, the SVM conference 13 years ago. She turned around and said, "You should be in the society and you should come and do these committees." And that's how we networked, and I got to meet all these lovely people here in the front row today. And probably a year later, I met Pam Mace at one of our early FMD conferences, and she encouraged me to become a FMD center at Emory where I practice. And fast forward 12 years, and here we are today. So I'm very appreciative of everybody in the front row and you all, the patients and family members, for being here. And I was tasked with giving you an introduction into some of the terminology with regards to the cardiovascular system. So give you a framework and a foundation for some of the lectures you're going to hear throughout the day. And while I was driving to Charlotte from Atlanta late last night in the rain, I decided we would have some fun with it. I decided to change my slides at midnight when I arrived to the hotel. So hopefully this lands well and we get something out of it. And you could tell me later whether it worked out or not, but I got some good ideas for those 4 hours of quiet time I had. And also thank you for the first 3 speakers. Those talks were so energizing and filling my tank, if you will. So I feel like we're ready to go and learn and dive in. And so we're going to explore some of this cardiovascular terminology with trivia. So this will be audience participation, but not with your phones. It's going to be old-fashioned hand raising, okay? And you could just shout out. This is going to be interactive, and we're going to play trivia. There's going to be about 6 questions, and keep track of how many questions you get right, okay? And we'll see at the end if anyone got all 6 of these questions. So question number 1, name the type of vessel that transports oxygenated blood from the heart to the organs and tissues. Good job. 1 point. 1 point to the audience. That's right. So artery. Okay. And for those of you who don't know, so the arteries transport oxygenated blood from the heart to the various tissues and organs throughout the body, and they supply blood that way, and the veins help travel the blood back to the heart where they become oxygenated and circulated that way. And the artery looks a little different from the vein. They each have 3 layers, right? From the inside out, you have the intima, and the media, and the adventitia. Okay, and as you can see with the artery, it has a thicker media. It's more muscular and elastic than the vein because it has to pump with high pressure the blood throughout the body. Question 2. What is the most common cause of stenosis or a blockage in our arteries? Well, plaque. Very good. Okay. Then you have to raise your hands. Everyone's just automatic this morning. We're on task. That's great. So atherosclerosis or plaque. That's right. And what is that atherosclerosis? So you can see with the cartoons on the left, that's cholesterol buildup, right? It's caused by traditional risk factors, high blood pressure, cholesterol, diabetes, smoking, etc. And it causes this buildup, usually where there's turbulent flow, perhaps at a bifurcation where the artery is splitting. Less common up to the right-hand corner of the screen is called vasculitis, and that's where you have a long tubular narrowing from autoimmune conditions or inflammation, the vessel that causes that compression or stenosis of the arterial lumen. And then lastly, on the bottom right, you can have fibromuscular dysplasia changes, which is fibrosis of the musculature, which leads to that hypertrophy, causes that classic beads on a string pattern, and those little inner webs that you can see causes the stenosis. So different types of stenosis, atherosclerosis being the most common. Question 3. What is the term for the inner layer of the artery that separates and tears into the arterial lumen? Okay. Good job. Okay. So that's correct. So an arterial dissection, as illustrated here, that's when that inner layer or the intima separates into the vascular lumen. Okay. And when it does that, it can lead to stenosis or blockage. It could obstruct this blood flow, and you could also get blood clots in that area, which can cause problems downstream from the artery too. What it's doing is it's creating what's called a false lumen next to that true lumen, and that false lumen can compress on the vessel and can cause problems downstream. So yes, that is a dissection. What is the term for the enlargement or bulging of the artery caused by pressure and weakening of the arterial wall? Aneurysm. Okay. So aneurysm. And there are different types of aneurysms, right? The most common is on your bottom left, and that's called a fusiform aneurysm. The way I like to describe this is the shape is when a snake eats a mouse, or if you're from Atlanta like me, maybe a Coke bottle appearance, right? So fusiform aneurysm is the most common dilatation or growth of that artery. Saccular aneurysm above that's a little less common, a little more unstable, then it looks a little more like a mushroom head with a cap there. To your right is called a pseudoaneurysm. That's typically the result of a dissection where there's disruption of the intima and the media, and it leads to that protrusion of the vessel wall, that little outpouching there. And we monitor those as well. And that's typically the result of a prior dissection, and that's called pseudoaneurysm. So different types of aneurysms, and you'll hear us use these terms throughout the day, and you're doing fantastic. Everybody keeping score? Okay, no cheating. So you've learned all these terms. We're all on the same page, right? Okay, so we have the foundation to move through some of these talks today. We know what artery and vein is, stenosis, atherosclerosis, vasculitis, fibromuscular dysplasia, different types of causes of stenosis. Dissection is a tear, aneurysm, and pseudoaneurysm. That's great. Okay, question 5. What are the 2 most common vascular beds involved with fibromuscular dysplasia? What arterial systems? What location? Perfect. Carotid and renal. Fantastic. This is a high-level audience. Next year, I'll have to make my questions harder. Okay, so that's exactly right. So FMD, we talked about this already. It's non-atherosclerotic and it's non-inflammatory, right? The etiology is unknown. You're going to hear a lot about this in the next few talks, but we know it does cause stenosis, occlusion, aneurysms, dissections in these affected vascular beds. And just like you stated, the renal arteries and the carotid arteries are the 2 most common beds involved in approximately 65% of the cases. And as you all know, it's more common in women and younger patients with an average age of diagnosis around 40 to 50. In multifocal FMD, or the beads on a string pattern, which layer of the artery is affected? We have 3 choices, right? Remember what those were? There's intima, media, and adventitia. Which layer is involved? It's getting harder now. Most of you said media, and that's exactly correct. Good job. So that's the media. That's the middle layer, right? And the histology is at the lower side of your screen. The middle layer is here. This is the media, and you could see there's thinning of the media right in the middle, surrounded by what's called fibromuscular ridges, okay, with some hypertrophy, and that's what leads to those alternating areas of stenosis and dilatation. And you can see that on a histologic level. And then on the angiograms, it leads to this beads on a string pattern, right? And this is in the distal internal carotid artery, or the mid to distal renal artery here. So the media is involved. In contrast or comparison, there's focal FMD, right, which is less common. It's more common in the pediatric patient population in adolescent boys, but that's a trickier diagnosis, and it causes a concentric focal stenosis here in the carotid or the renal artery, respectively, and that can sometimes be a mimicker of other things, like we could be mistaken for vasospasm or atherosclerosis or dissection, for example, and on histology it looks completely different. Here it's that inner layer or the intima that causes that discrete focal stenosis. So that's focal FMD. And we used to use that as our clinical criteria. We would refer to FMD as either medial or intimal, right? But and that was dating back to the 70s. And over the years, we weren't doing much histology. Most patients, thankfully, didn't need surgery. And the diagnosis is angiographic, like I mentioned, with the beads on a string pattern. And so we were making a histologic diagnosis based on angiographic or clinical criteria. So fast forward to 2014, we came up with the angiographic criteria, which is now termed multifocal or focal FMD. Multifocal corresponds with the medial type, And vocal corresponds with the intimal type. Okay? So helpful to have this terminology moving forward. Last question, what are the two most common presenting signs and symptoms in patients with FMD? Sorry, I didn't hear. I mean, I heard a lot, but I didn't hear anything clear. Say again. Good. Perfect. Okay. Did you all have these slides in advance? Okay. Okay. That's exactly right. Hypertension and headache, and headaches can be very debilitating as well, right? Over 50% for both of these, not uncommon, and something to think about, especially when we see younger patients presenting with these signs and symptoms and don't have traditional risk factors. And this is from one of the first publications from the US FMD registry that presented these signs and symptoms. You can see hypertension and headache. I also highlighted pulsatile tinnitus, which is that whooshing sound that you may have heard of, or some of you may experience in your ear from the turbulent flow in your carotid arteries. Okay, so good job. Who got all six? Okay, so we have a few. Okay, I wish I had a prize for you, something, but congratulations. You have my respect. That's great. And you're all front row, so that checks out. Okay, so we had about four. How about five answers correct? Okay, four. Okay, very good. Well, thanks for playing. So, sorry, one more case. We're going to apply our knowledge. So this is a real case, but I hear you. That's means hurry up. 43-year-old woman presents to clinic with severe hypertension and headaches. She had a history of smoking and a possible family history of an aneurysm. Okay, her blood pressure remained over a systolic of 160 despite two medications, so she was referred to our vascular medicine clinic. In the office, her systolic blood pressure was over 200. So we did a renal duplex ultrasound. Some of you may have had this diagnostic test, and this is what the ultrasound looks like. On the left-hand corner of your screen, we're measuring the velocity. And in case you don't know, fluid in a column, if the cylinder narrows and flow is constant, then the velocity is the variable that has to elevate. So elevated velocities correlate with stenosis. In the middle, you can see turbulent flow from that speckling mosaic pattern in the color Doppler, and that is similar to what I could describe as whitewater in a river, if you've ever talked to me about this in clinic, turbulent flow. And on the right-hand side, you see that dilatation and swirling in the artery here. What do you think that is? We discussed one of these terms today. This is probably an aneurysm. That's right. Okay, so she has fibromuscular dysplasia, and we confirm that with the renal angiogram. So here's the right renal artery with that multifocal beaded pattern and the aneurysm distally. Okay. The PD to PA ratio is where we take a pressure wire, advance it past the multifocal beading, and measure a pressure distally and compare it to the pressure proximally. And if that ratio is less than 0.9, then it's hemodynamically significant, and we proceed with a balloon angioplasty to treat the patient's resistant hypertension. The left artery has a little bit of beating, but not as bad, with a ratio that's over 0.9, so not hemodynamically significant. So we proceeded with the balloon angioplasty on the right. We did a post-procedure gradient, and that ratio is now over 0.9, so it was a successful procedure. And dramatic blood pressure reduction, stable on one medication, headaches improved, and the follow-up renal ultrasound was normal. So thanks again. Hopefully that gives you, we're now on the same page, we're speaking the same language, and look forward to the rest of the day.